Hi everyone, in this video I will be going over assessing psychopathology and filling out the diagnostic justification section of the Department of Mental Health assessment. So when assessing for psychopathology, we don't go through every single disorder in the DSM and check off symptoms and ask about every single thing that we see in there. That would take way too long and just really isn't an effective way of assessing for psychopathology. Instead, we look for predominant symptoms, some of which cut across several different disorders, in a way to kind of narrow down potential diagnoses and identify the client's primary symptoms. In doing so, it can be helpful to think of symptoms as occurring in clusters. So for example, in the depression cluster, we would be looking for symptoms like sadness, hopelessness, isolation, and so on. And so thinking of assessment, diagnostic assessment in this way can help to make sure that you assess for all major symptoms without becoming overwhelmed by the sheer number of disorders that you'll find in the DSM, and without having to interrogate your client with regard to every single symptom that you see in the DSM. Viewing symptoms in clusters can also help you to organize information that the client is giving you. So for example, if your client were to talk about struggling with falling asleep or staying asleep, you would place this particular symptom in the sleep cluster and also potentially in the depression and anxiety cluster, and start to organize the information in that way. Even split in clusters this way, it can still be a lot of clusters to go over. So the American Psychological Association has developed a self-report measure that can help to narrow things down. And I'm going to be focusing in on that over the next couple of slides. This is a 23-item measure that clients fill out and report how much or how often they've been bothered by a series of symptoms. This measure captures information on each of the symptom clusters that were featured on the previous slide, and this measure is free to use and available online by clicking on the link that is here or typing that into your browser. So what I've done here is provide a screenshot of the first half of that measure. The full measure is also uploaded on Canvas for you if you wanted to follow along using that in front of you. Okay, so each section that you can see numbered in Roman numerals here corresponds to a specific symptom cluster. And each cluster has a certain threshold at which point further assessment is warranted if the client were to select it. So for example, for sections 1 through 5 on this page, a client rating mild, which is a 2, or greater warrants further inquiry, which means that you would need to follow up with either a more narrowly focused self-report measure, or perhaps more ideally, a clinical interview to ask more about that particular symptom cluster. Now that's different from other sections like section 6 on this page, where slight or greater warrants further inquiry. So it's going to depend on the particular section that you're in. So let's go through each section. So section 1, which has 2 questions, is assessing for depression. And you can see that question 1 is looking for anhedonia specifically, and question 2 is assessing for depressed mood. Were the client to score a 2 or greater in these items, you would follow up with a more thorough assessment of depression. This could include, as I said, another self-report measure, but one that is specific to depression, such as the Beck Depression Inventory. Or what I personally would recommend is that you follow up with a diagnostic interview that hones in on their symptoms and experience of depression. So questions might include, what was it like when you felt down, depressed, or hopeless? Or what was it that you lost pleasure in? How long did that last? And so on. And so this is going to help you to pinpoint specific symptoms in this depression cluster that would be useful for diagnostic purposes, without necessarily having to fill out an entirely new questionnaire, which may feel a little impersonal. Okay. With each of these that warrant further inquiry, you would then guide your questioning so that you get the onset, frequency, duration, and intensity for each of the symptoms. And so, for example, the little interest or pleasure, if that's rated higher, like mild, moderate, severe, then you're going to follow up with that and find out when did that start, how often does it affect the client, what are specific circumstances surrounding it, and so on. And then the same thing for the down, depressed, or hopeless, and for every other depressive symptom that you then subsequently assess for. Okay. Now, other questions about depression should come from your knowledge of the DSM and the diagnostic criteria for a major depressive episode, for example. So you don't escape knowing your DSM. You've got to know it. But what this does is help to narrow down which disorders you're going to want to hone in on, okay? So you would do this for every other section, and I'm going to go over each one briefly and provide you some suggestions about questions you could use to follow up with, as well as name a self-report measure that you may want to use if you're wanting to go that route. Do note that we will go into self-report measures in much more depth in a later video. Okay, so section 1, depression, check, we got it. Section 2 is one question about anger, and some follow-up questions you might ask if this were rated at 2 or above would be, tell me about the times when you felt grouchy or irritated, using the language that's in this measure. Or tell me about the times when you felt like you had a hard time controlling your anger. And then based off of what the client tells you from there, you ask further elaborating questions. If you wanted to use a self-report measure, the PROMIS emotional distress anger short form is one that focuses in specifically on anger. Next is section 3, which has 2 questions, and these questions are screening for mania or manic symptoms. Okay, if you wanted to use a self-report measure to follow up on this one, the mood disorder questionnaire would be an appropriate one to use. Questions you could use in a diagnostic interview to follow up on manic symptoms could be, tell me about the last time you felt like you had so much energy that sleep didn't feel necessary, or how did other people in your life respond during this time? You could also ask the client to describe it in a little bit more depth what they did with all of their energy to get a bit more information about what this potential episode might have looked like. Section 4 has 3 questions and is screening for anxiety. An appropriate self-report measure to follow up on this one, again, if we had a 2 or a higher, would be the Beck Anxiety Inventory, which has been used in lots of different populations. Some follow-up questions. Have you ever had a panic attack when you suddenly felt frightened or anxious? When did these attacks happen? What were you doing? How long did they last? Those would all be great questions to ask. Okay, section 5 here is about somatization, right? And this one is a bit of a harder one to find a specific measure for. I think they do have a PROMIS emotional distress one for somatization specifically, but you could also use the PHQ-15, which has some of the somatization components to it. So questions you could ask your client if they scored a 2 or above in this section. Tell me about the first time you noticed these unexplained aches and pains. Once again, remember that's what it's asking in the questionnaire, so it makes sense. Have you found anything that helps relieve the pain? May be helpful to assess for both coping and to see what kind of treatments they may have gotten in the past. Okay, and the last section on this half of the questionnaire is section 6, which is about suicide. And here a rating of 1 or above warrants further assessment. You could use the Beck scale for suicidal ideation if you wanted to use a self-report measure, or you could do your screening verbally with questions like, tell me more about the times when you felt like hurting yourself, or how often do you find yourself thinking about death throughout the day? And of course, you would go on from there. Okay, here's the second half of this measure. And we have a couple more sections here that are screening for other symptom clusters. So we'll go over those now. Section 7, which is up at the top, has 2 questions and is screening for psychosis or psychotic symptoms. If you wanted to use a self-report measure for this, you could use the Positive and Negative Syndrome Scale, or the PANS for short, or you could ask follow-up questions like, do you ever feel like you see things that others don't? Or do you ever feel like you hear things that others don't? Do you ever hear things that distress you? And so on. Section 8 is one question about sleep problems. It's a very general question, so any score here that warrants further assessment, you'd want to elaborate much further. You could use the Pittsburgh Sleep Quality Index if you wanted to use a self-report measure, or you could ask questions like, how long does it take you to fall asleep? Do you feel rested when you wake in the morning? Do you find yourself waking up often in the middle of the night? And so on. Section 9 is also one question and is screening for memory problems. And these are actually screened for using the same questions that you used in the mental status exam. So if you've forgotten what those are or you want a refresher, go back to the video about the mental status exam and take a look at the screeners for memory problems. And remember, those were broken down into immediate, short-term, and long-term memory. Next, section 10 is about repetitive thoughts and behaviors, which you may see in obsessive compulsive disorder. So a self-report measure you could use here would be the Yale-Brown Obsessive Compulsive Scale. You could also ask questions, as always, like, are there things that you feel like you had to do over and over again and couldn't resist doing? Or what would happen if you didn't do those things, to get at some of that anxiety? Section 11 is about dissociation. It has two questions. Right? Yes, two questions. And you could use the CAPE 42 to assess for dissociation if you wanted to. Or you could ask questions like, do you ever feel like you're watching yourself from above? Tell me about those times when you felt detached from your body. And section 12, I'm sorry, section 11 was one question. Section 12 is two questions, getting my Roman numerals messed up. So section 12 is about personality functioning, and I'm going to skip this one for right now because I'm going to focus in on it a bit more in the next slide. The last section is about substance and alcohol use, and if you wanted to use a self-report measure, the audit would be a good one to start with, and we'll go over that when we do the substance use module. But really briefly, you could ask a simple question like, tell me about how many days a week you use substances or alcohol. So this would be a great one to use as you're diagnosing your mock client, to have them fill out and help narrow down disorders for you, and to see which areas you need to focus in on and which particular areas you need to ask more questions about, and to help keep you from having to go through the entire DSM. But don't forget your knowledge of the DSM as you are going through the follow-up to guide your questions and make sure that you ask about everything you need to. Okay, as I mentioned, we're going to focus in a bit on personality disorders here. Personality disorders can be challenging to assess and to diagnose. Your supervisor may actually recommend that you refer the client for a secondary evaluation or a more thorough assessment using tools that perhaps you're not trained to use, maybe a psychologist or a psychiatrist referral. However, if you're instructed to give it a go and assess yourself, the structured clinical interview for DSM-4 Axis 1 disorders, or the SCID, can be helpful. Note that this one that I'm showing you, it has not been updated for DSM-5. There is an updated version for the DSM-5 and for personality disorders specifically, but it's not free and it can't be shared without permission from the developers, so I can't show that one to you. But I have uploaded the SCID for the DSM-4 onto Canvas if you're wanting to use it. So I'm going to share what that looks like with you now. Okay, so here is the personality disorders section of the SCID, and it starts on page like 202. So it's a very long measure because it's basically a structured interview prompt. And so you would follow it and ask all of the questions and the probing questions as well. But you can see this one in particular starts off with borderline personality disorder. There's a section like this for every personality disorder. And there are questions here about relationships, sense of self, identity, impulsivity, and so on. And so remember, for personality disorders, as you're going through these questions, that you're looking for behaviors or traits that are characteristic of the person's recent and long-term functioning since early adulthood. We're not diagnosing a personality disorder if the behaviors are the result of an identifiable stressor and not really normally reflective of the person's characteristics. So for example, a person who's going through a divorce may feel frantic thinking about the person that they love leaving them, which is this first question that you see up here. This is very likely due to the circumstances of the divorce and not because this person has borderline personality disorder. That's not to say that they don't, but you need to assess a lot further to see. You wouldn't just assume that because they feel this way, then they must have this disorder, right? We're looking for a consistent pattern or consistent characteristics of this person's personality throughout their early adulthood. And we're making sure that we are taking stressors and particular circumstances the client is dealing with into consideration. Okay? We also need to be mindful that some of the characteristics we're looking for may be seen during an episode of another mental health disorder. So something that they endorse here may be because of an underlying depression as opposed to a personality disorder. So unless the behaviors and symptoms are a characteristic feature of the person's long-term functioning, and they're not limited to a particular episode of another disorder, then we aren't diagnosing it as a personality disorder, okay? So you'll see these questions, and as I said, they go on quite a bit. and then you get to the next disorder. So here's antisocial personality disorder, and so on. And so these questions serve to guide your questioning. You basically are asking what the document says. So before you were 15, did you often bully or threaten other kids? And if the client says yes, you would then say, tell me more about that and find out more information and progress through this document to assess the entire section for each personality disorder. Okay. For each of these items, if a client endorses them, we could also follow up with more specific probe questions. So I'm going to read you some of those in the PowerPoint now. Okay, so some potential questions to follow up with. If the client does endorse some of these symptoms on the skit, give me an extreme example of this. Does that happen a lot in a lot of different situations? Have you always been or have you always felt this way? Do you think you are more this way than most people? Has this caused any difficulties in your life? And so on. So trying to get at whether or not this particular symptom is characteristic of this person's long-term functioning, as opposed to just this one isolated situation. Okay. Now that you've got information about your predominant symptom clusters by doing that self-report measure, perhaps by following the SKID to assess for personality disorders, you should be able to narrow down your diagnosis. So then you're going to go to that section of the DSM, such as the mood disorders section or the trauma section or what have you, and you're going to check the diagnostic criteria of the disorders that you're considering to see if the client meets them. This is also where, if you need more information, you can be sure to follow up on that information, on those missing pieces in your next assessment session. This is when it's really helpful to have a strong knowledge of the DSM, because then during this diagnostic interview, you're pulling from memory the different symptoms you need to assess for. Like if I'm assessing for depression, I know I'm going to have to assess for appetite, for sleep, for motivation, for hopelessness, for loneliness, because I know that those are characteristic of depression. So the stronger you have a knowledge of these different disorders and their predominant symptoms, the easier it's going to be for you to pull this information in and ask the client about it in the moment, as opposed to having to bring it in at a next session. But if you don't remember, or you forget some things, or you find as you're going through the criteria that you missed something or you want more information, make sure to ask at your next assessment session. Okay. Oh, and the last thing here, you do want to make notes. Jot it down or put it in your notes somewhere. Other disorders that you might need to be mindful of in the future, things that perhaps the client is close to meeting criteria for, but maybe hasn't met the timeline yet, or you need to find out more information about certain other symptoms or what have you. Keep a mental note of those or a written note so that you can make sure to continually assess as you work with the client. Okay, so with this information completed, we can now move on to completing section 9 of the DMH assessment, which is the summary and diagnosis section. What's kind of nice about this section is that it starts with client strengths. So this allows us to make sure we're not letting all this pathology talk keep us from remembering our client's strengths. So here, what we're going to do is, first off, absolutely ask the client what they think their strengths are, but then also help the client to identify them potentially if they're having a hard time or if they're missing something that you think is an important strength. Remember that it can be hard to see our strengths sometimes, and the same is true for our clients. So here's an example that includes the client's own reports of his strengths, which are photography and academics, as well as the therapist's perception of his strengths, pro-social skills. And notice that evidence is provided for each. So the first sentence, client reports his strengths are photography and academics. Sorry, there's a repetition there. And then there's an evidence given for that. Specifically, the client enjoys photographing nature scenes and going to remote places to take pictures. So he struggles to feel proud of his work. He acknowledges that his pictures are well liked and well done. Okay. So that's helpful. So what is strength? And then give evidence of it. Then I give evidence of the academic part. And then toward the bottom, I indicate a strength that I've identified as the therapist and give evidence. Okay, so this is the strengths section. Then we have the clinical formulation and diagnostic justification. This is a really important piece of your assessment because it is probably one of the most important pieces of justifying medical necessity. Probably other than the presenting problem section, this is the one that really is supposed to emphasize medical necessity. So because of that, DMH is looking for really specific components in this section, and it's important that you include them even if you've already discussed them elsewhere in your assessment. So you'll notice here it asks about impairments in life functioning. And if you did the presenting problem section correctly, you've already done impairments in life functioning. That doesn't mean you don't include it here. You must still include it here. All that it means is you get to pull from that information because you've already done it. Okay. So we're going to go through each of these separately. Okay. So first, summary and conceptualization. Here we want to know who is the client very briefly. And so I have here Julius is a 28-year-old single African-American male who was referred for treatment due to depression and suicide attempts ×3. So that also gave me a little bit of the presenting problem. Okay. And then elaborate a little bit more on the symptoms. That's the presenting problem. So depressive thoughts, and I explain what those are, contribute to feelings of hopelessness, sadness, and despair. Okay. And then your conceptualization of the problem is going to be based on your theoretical orientation. So I've taken a CBT approach, and I explain really briefly. These thoughts and feelings contribute to depressive behaviors, including isolating, not following through with responsibilities, pushing others away, and suicide attempts. Okay. So who is the client? What's the presenting problem? And how are we conceptualizing it along here? Okay. Next is the diagnostic justification. And here we are going to label or identify which disorders the client's symptoms have met criteria for. Okay. And so you would include the name of the disorder and the symptoms that are met, being specific to this client. So not just listing off every single diagnostic criteria in the DSM. That's not helpful. And then you're also including differential diagnoses. So my first sentence here tells you what the disorder is, including relevant specifiers and severity. So client symptoms meet criteria for major depressive disorder, recurrent, severe. Okay. Then I'm giving the specific symptoms that satisfy the criteria. I'm not just listing what it says in the DSM. I'm talking specifically about this client and giving frequencies and intensities where appropriate. So client reports feeling hopeless all day, every day, and they give a percentage of time per day, how many days a week. Thinks about killing himself every day, percentage, how many days a week. And is withdrawn and isolated, percentage, how many times a week. He sleeps most of the day, percentage, times a week, but can only get about 2 hours of sleep at night. Has lost 25 pounds in 3 months due to loss of appetite and not caring for himself. Client has experienced severe episodes of depression since roughly age 25. So I've given enough information here to justify a diagnosis of major depressive disorder. This is where you show that you've done your assessment well and that your diagnosis makes sense. If you are writing that the client has major depressive disorder and then you go on and describe a bunch of trauma symptoms, that doesn't make sense and your disorder does not make sense. Remember with the clinical loop that we want to make sure our assessment informs our diagnosis. So everything that's been leading up to this at this point should be consistent with what you're diagnosing, and you should have lots of evidence for it. If there were differential diagnoses in this case, I would add those at the bottom of this section. In our case, there aren't. Okay, next is the functional impairment. So remember the life domains that we're looking at: family, legal, school, work, living situation, and so on. If you did this well in the presenting problem section, you can essentially repeat the information here. We're looking at which domain or domains are impaired and how are they impaired. Don't forget the how part. Okay, so since client's last hospitalization, moved into brother's home and feels guilty that he's caused his brother pain. Client's depression contributes to pushing his brothers and friends away because he doesn't want to burden them and doesn't feel like he deserves their love. So here is an impairment of family and social, right? Pushing brother and friends away, and it's linked directly to the depression. Doesn't want to burden them and doesn't feel like he deserves their love. Okay. Next, his depression has also made him lose his job, an employment impairment. How? He couldn't motivate himself to go to work. Okay, linked. Client reports he's not currently working and only gets out when my brother makes me. Client's academic goals have also been impaired, so education. How? He feels hopeless about ever being successful, making him drop out of college. Okay, clearly linked to his depression. And then if some do not apply, client denies any legal problems or issues with his living situation at this time. Okay, this functional impairment piece supports your diagnosis and also supports medical necessity by showing that the client's symptoms are impairing them significantly enough that they need treatment. Okay, Next section is risk factors. And here we're looking at any potential crisis issues, suicidal ideation, homicidal ideation, self-injurious behaviors, or psychosis if applicable. And we're looking at other stressors that might be contributing to the client's presentation, such as homelessness or financial stress. So here, client symptoms have resulted in 3 suicide attempts through overdose. Okay, that's a crisis issue. Client denies SI at this time and agrees to creating a safety plan with therapist. Client reports, I want to have hope again, this is no way to live. Okay, so this is addressing the crisis issue. And then client denies HI-SIV psychosis at this time, showing that I did assess for it and it's not relevant to the client at this time. The last section of this part is the strengths. And remember, we did this at the beginning of this section. And so you're going to repeat them briefly. Okay, what makes this unique in this part, as opposed to what we wrote in the client strengths section, is that we're linking the strengths directly to treatment, meaning how could the strengths be a potential coping skill, for example. So remember, this client's strengths are photography and pro-social skills, according to the therapist. So I write that. Client skills include photography and pro-social skills. And then how are we going to potentially use them? Client agrees to implement photography as one of his potential coping skills in the safety plan. Okay, clearly linked. Client's pro-social skills can serve as an asset in supporting the development of social support and reducing isolation. Clearly linked. Notice that I didn't include academics here because I didn't see how I could link that directly to his treatment. Okay, but it's still included as a strength in the client strength section. All right, so this finishes up the clinical formulation section of the DMH assessment. The second to last piece on this page is the diagnostic descriptor. And this is where you're writing out the actual diagnosis or diagnoses. On the left, where it says diagnostic descriptor, you're writing the full name of the disorder with corresponding severity and specifiers if applicable. On the right, you are indicating whether each diagnosis is primary or secondary. If you only have one, you only check off primary. Okay? And then you would write the code, and you need to write the ICD-10 code. Okay? In the DSM, this is the number that's written in parentheses and starts with the letter F, like Frank. Okay? If you're diagnosing using a Z code, which is okay, that would be written here as well in the diagnostic descriptor. But note that writing no diagnosis cannot be used for the Department of Mental Health. So in the case of my client, I have diagnosed him with major depressive disorder, recurrent severe. Remember, I wrote that in my clinical formulation. So that would go on the left in the diagnostic descriptor section. That is the primary diagnosis, so I would check off primary. And the ICD-10 code for that particular disorder with that severity is F33.2, and that is what I would write in the code section. Finally is the disposition plan section, and this is the final part of this section in the DMH assessment. Here you're writing 2 to 3 sentences about what kind of service the client will be receiving, any referrals that you're providing, and any special services like community-based work. So I've written here, client agrees to outpatient treatment, that's the type of service being provided, a medication evaluation, my referral, and safety planning to address my suicide risk. Client will attend individual therapy 1 time per week, getting a bit more specific about what kind of service I'm giving. Services will be provided in the office when possible and in the community when necessary due to client's transportation limitations. This is where you're going to indicate any type of community-based work and why you're doing it. Finally, client will be referred for a psychiatric evaluation with the in-office psychiatrist. Okay, and that finishes this up. Right. So that is the section of the DMH assessment having to do with psychopathology and diagnosing. I know that it's a lot, so let me know if you have questions or if you need any clarification with anything, and I will see you next time.